Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator.
Welcome to another series, another portion of this dental webinar series. Today, we're going to be having some periodontists in the house today, because I think implant placement should be, a team approach in terms of how it should be done, in terms of the surgeons, the prosthodontists, the restorative folks, as well as the periodontists. It should be a team effort, and that is what we are moving towards. Hopefully, I need to reach out to different schools. We want to see how we can come up with, an integrated implant curriculum for predoctoral students as well as residents. So I'm looking forward to having a meeting with all faculty members in the 13 Nigerian universities. Hopefully these webinar series will translate into that, and hopefully we'll have an integrated course that is supported by us, by dental supply companies, to have a laboratory component. So that's my goal. I'm looking forward to having that happen. I'm going to turn off this right now, and let's get into the. So today we are blessed to have two gentlemen in the house today. I'm just going to start off with the first speaker. The first speaker is. These guys, they look so handsome in their photographs. I don't know how. Anyway, but we have Dr. Khaled. Sinjab is a graduate of the Department of Periodontics and Oral Medicine at the University of Michigan. He received his dental degree in 2010, and his passion for periodontics pushed him to join the one-year postdoctoral program in 2015. He later joined the residency program in 2017 and has dedicated his residency in treating patients as well as dental-related research. He is a proud recipient of the 2018 Delta Dental Award, the Rackham Block Grant Award, the 2018 IDR-EF Grant, and the Rackham Graduate Student Research Grant. His research focuses mainly on dental implants and peri-implantitis, and he has published many papers on the matter. Thank you so much, Dr. Sinjab, for accepting, for your willingness to come and present in this series. Please go ahead and take it away.
Thank you so much for having me. I really appreciate it. I will start by sharing my screen. And it's an honor for me to be presenting today for you with my amazing colleague, Dr. Ricardo Di Gianfilippo. Me and him have been together for the last 4 years now, three and a half years, I would say.
Always too nice.
Yeah, it's been awesome. So I will begin. I'm sorry, I just need to minimize this because I cannot see my own screen. Minimize, there we go. And then we're gonna hit play. So I hope you're all excited as much as I am today about this topic, implant surgery and sinus augmentation. So really quick, this is gonna be a way to make everybody laugh. The reason why I have a picture of a squirrel holding a tooth is because my last name is Sinjab, which means squirrel. So this will be my logo for Sinjab Periodontics. It's a squirrel holding a tooth instead of a nut. So for us here, it's a very beautiful morning here in Michigan. This is the University of Michigan Central Campus where we go to school. The dental school is where the M is. There I have an amazing group of colleagues and professors and classmates that I go to school with there. And we just recently graduated, me and my 3 colleagues, Dr. Tavelli and Dr. Wong and Dr. Summer. I'd like to make sure that everybody knows that I have no conflict of interest regarding any of the presentation materials or techniques. I'm just going to go over a few things. And I'd like to start by saying, instead of going through everything all at once, I would like to present it in the form of a case. So let's say we are all dentists and a patient came into our office like this. So this patient, her name is Joan. She's 70 years old. She's very healthy. She doesn't take any medications except vitamins. And she came to my office, and she came to the department, sorry, not my office yet. And I asked her what was her chief complaint, and she told me that my doctors told me that my upper first molars, both sides, are ready to be taken out. You can see from the picture, and later we're going to discuss more, you can see in the upper right picture, there's a fistula in the area of the upper left first molar. But the reason was because she had those molars root amputated, and we know from the literature that the survival rate of the molars with root amputation up to 10 years is about 70 to 80%. So from there we can say, okay, so now these teeth, they are ready to be extracted. What is the plan? Again, I know everybody's looking at the arch wires and all the screws that are in her jaw. Those are all being monitored by the oral surgeon. Again, I'm not going to be treating everything, just what the patient was referred to me for, and that is the first molars. So looking at the sinus right away, you see that the sinus has been pneumatized on the right. It's actually on the left of the picture, but on the axillary right molar. And that tells me that eventually after I extract the tooth, I may need to do a sinus augmentation there. On the left side of the patient, we see that the sinus has not been pneumatized, and there's a chance for us to reconstruct the arch. So for the left, we did a socket augmentation, and I used a PTFE membrane. This one is called a dense PTFE membrane. The pores are smaller, so you can leave it exposed. And after 4 weeks, we remove the membrane. You can see the bone. And then this space is filled up with keratinized gingiva. And this was at 3 months. Looks beautiful. However, on the maxillary right first molar, the infection was pretty bad that we did not recommend bone grafting. So we decided to just put, a few sutures to allow it to close by granulation and a secondary healing. And this was it at 3 months. Now we do a CBCT scan. What do we see? You see the pneumatization and you see the ridge collapse. On the other side, you actually see that the bone filled beautifully, right? So what are we going to do? These are the dimensions you see. For here in America, we use the numbering system 1 through 32. So upper right first molar is number 3. And we have a height of 5 millimeters, but we have sufficient width. So what are we going to do? This is what we're going to talk about today. And we have sufficient width of 8.8 millimeters. That's great. However, what would we do if we had less than sufficient? That's what Dr. Ricardo is going to be talking about today. He's going to be talking about the GBR component, because we know you do not place the implant where the bone is. This is a big misconception that was going on back in the early 2000s. A lot of dentists were placing the implant where the bone was and then modifying the denture or modifying the prosthesis. What we want to do is we want to place the implant where the prosthesis is going to be, and by that we modify and configure the arch. Here, this is the picture of the sinus in a cross-sectional area where the implants would have been placed. We can see that there is a palatonasal recess. However, the angulation is not too narrow and it's not right above the center, so that doesn't give me a huge complication. And we're going to discuss about that later. So this is now the upper left again. You see how beautiful that ridge became, and you see that we have enough width to place the implant. We placed the implant, but the bone was pretty soft, so we decided to stage it. The area then had sufficient keratinized mucosa, so we ended up doing a tissue punch and later restored the implant. So that's beautiful. Now for the right, what are our treatment options? We can either do a implant with sinus augmentation because we want to increase the vertical height, or replace a short implant. Do short implants work? I've been asked this before, if short implants work. A lot of studies out there, they talked about this and they said that short implants have shown that they have just as good of a survival rate as long implants. However, because of the short durations of these studies mostly have a 5-year follow-up, mostly in the literature. But ones that have been doing randomized clinical trials and not case series have found that they have a good survival rate. However, yes, okay, so if we want to say that there's an advantage, it's because it's short, so there's less pain and procedure time because you're not doing a sinus augmentation. But they recommend to always use a wider short implant for the occlusal table of the crown. And then a study done by the University of Michigan, they did a meta-analysis comparing these two, and they found that a 3-year follow-up shows a similar treatment option. However, they recommended that if you're using multiple short implants, you should always splint them together because that will help with reducing any prosthetic complications. Now, for me to consider an implant procedure, I need to consider the following. I need to consider what's the restorative plan. Who is the restoring dentist? What do they want to do? I wanted to consider the surgical field. Are there any factors that I need to consider if I'm going to do the surgery? Is it going to complicate, or am I going to have any issues in the healing process, for example? Local factors, we're going to go through all of those later. And then finally, in this part, I'm going to talk about achieving implant stability. So if I'm going to do a procedure where I'm going to do a sinus lift and place the implant, can I place the implant at the same time? You have to distinguish the quality of bone, the width, and the height. If I were to place a short implant, so for example, in this scenario, if I placed a short implant, would it be able to achieve primary stability? I'm sure it will because we have enough bone width and the bone quality was solid. But I'll show you in a second why we didn't. And then we have to talk about patient concerns. What does the patient want? It's not about what you want, it's what the patient wants. If the patient says, I want the cheapest, and you said, I want you to get an implant, you're not going to be able to force that on them. Ridge dimensions, that's important because you want to know if you're going to do GBR. Sinus pathologies, that's also very important because would you need to refer to an ENT specialist for treatment? You don't want to put bone graft in a sinus that has a pathology. Now you're in a bigger situation. Finally, patient-related factors. This can be involving any of the systemic conditions that can be contraindications, or we're going to talk about it later, religion and allergies as well. You may ask, wow, how is the religion involved? I will tell you in a minute. So this is the sinus now. We see this tooth right here. This is actually the third molar. So the third molar has now moved into the second molar position, and it's angulated in a way where if I were to put the prosthesis of the new implant or future implant, you will see that there's a big gap that's going to be there. That's going to be a major factor. What are we going to do there? So you have to talk to the patient. I either make a gap bigger so it's easier for them to clean, or I have to make the crown bulkier, which makes it harder to clean if anything gets stuck in there. Always make it easier for access and for cleaning. And then you want to talk about the distance between the two teeth. So here we have a distance of about 10 millimeters. So it's a wide space. I want to say 10 to 11. So if I place a short implant, imagine that big wide occlusal table being distributing the force on a short implant. I would like to see this last longer than 5 years or 10 years. So I decided to go with the longer implant. Also, the ridge width, because of the ridge height collapse along with the sufficient ridge width, we decided that it was more predictable to do a sinus procedure, place a long and wide implant, and this way the patient would be happy. So this is a study that I read recently that I really liked. They although it's a retrospective CBCT analysis, what they did was they looked at all the patients that received an extraction and had a CBCT before the extraction and after the extraction. A lot of times I was under the impression that when you extract a tooth, the pneumatization of the sinus happens because you extracted the molar. And that has been quite incorrect. I've been noticing it in the office, but again, this study has been able to show it to us. Most of the resorption or the loss in crest height occurs from the crestal part, while only a small percentage of about 12% occurs from the sinus. So if you see sinus pneumatization before the extraction, that's when you know you may need to graft later on. However, some sites, if there wasn't a lot of pneumatization, don't expect the pneumatization to occur right after the extraction, okay? Now, sinus augmentation is when you need to increase the vertical height, okay, in the posterior maxilla. That's it. That's the only time you would do it for implant placement. If you needed to gain on the other side of the sinus, that's when you're going to need to do vertical GBR, and we're going to talk about that later. There are a lot of contraindications. Some of them are surgical contraindications, just general surgical contraindications. If a patient had chemotherapy recently, immunocompromised, uncontrolled diabetes, heavy smoker. The ones for sinuses that you should be aware of are the acute sinusitis or patients that have recurrent sinusitis, because you could place the bone and then they could get a sinus infection and then everything gets infected. Now you have to wash everything out. And then you have any tumors. That's why we always do a CBCT scan. And then scarred and hypofunctional mucosa. With these three, I always refer to an ENT specialist and to follow telepathy. Sorry, we're not going to be doing the lateral sinus. There are different classifications. I will not go through them in detail, but just to show you how no two sinuses are the same. And sometimes they get even harder and harder, as you can see, shifting to the right side of the screen. So you always have to anticipate what's going to come to you before you do the procedure. And then also you have to consider the width of the sinus. Why is that? Because when you're going to be elevating the membrane, and I'll show you later, a narrow angle will make it much more difficult, and you can cause a perforation in the sinus. What is a perforation? We're going to talk about that as well. This is a study done by Dr. Wong and Contraindications where they classified the sinuses and they recommended for each category a specific treatment. So the three things that you want to consider are the ridge height, how much do you have in order to place the implant? And here they said more than 10 millimeters, 6 to 9 millimeters, less than 5. This was back in 2008 where a 10 millimeter implant was considered standard. Nowadays, here in America at least, I'm not sure about Europe or Africa, but 8 millimeters is now being considered the standard. So you can always change these numbers by minusing them by 2. Anyway, so the ridge height, and then you have the ridge width being more than or less than 5 millimeters, because that's how much you need at least to place a 3.5 millimeter implant or 3.7. And then the distance from the CEJ, because we do know that the more distance you have from the CEJ, the bigger the profile you're going to need for that prosthesis. And so for us, ours was a Class C vertical, where we have about 5 millimeters, and we have a distance of 4.8 from the CEJ, but we have sufficient width. So for that, according to their literature, they recommended that we do a lateral sinus elevation. We can place an implant simultaneously, but that would be recommended based on the implant stability. For this patient, we decided to just go for the sinus lift and not place the implant. And again, when you have a patient that has poor oral hygiene or lack of compliance, or health-wise, you're not so sure, you can always play it safe by doing the sinus procedure first and then later placing the implant. For this patient, she asked to do one first and then the other because she wanted to play it safe. However, we didn't have to in her scenario. There are 2 different ways to elevate the sinus. There's the crestal approach, where you come in from the crestal part and you can lift, and the lateral part where you come in from the side. What's the difference? Let's see here. So The benefits of the crestal part is that it is a shorter surgical duration. There's less morbidity, and usually we do it with the implant placement. However, the disadvantages are when you're lifting the sinus, you're not seeing what's going on inside the crest. You're just feeling. You're feeling the pressure. If you perforate the sinus membrane or the crestal wall, and you end up in the sinus, then it's going to be hard for you to manage or control the area. Also, patients find that there's more post-operative discomfort because these procedures are sometimes done with the osteotome technique. That's where you tap the bone in the sinus. And you can only lift so much. Studies have found that the lifting of about 5 millimeters is average before you can increase the risk of tearing or perforating the sinus. With the lateral approach, you have more visibility. You're seeing right in front of you. You're seeing the whole area of the surgery. You can put as much bone graft as you want because you can lift as much as you want, and then you have the ability to manage an irregular sinus floor. Because you're seeing the sinus floor right there in front of you. However, there are some challenges because there are some anatomical structures there, like the artery or the palatonasal recess, and this requires a longer surgical duration. So we decided to go with the lateral approach. Let's see. There are many techniques. I'm not going to bore you with all of them. I'm just going to tell you we decided to follow one technique, and I'll explain to you why. But like anything in dentistry, there's always going to be ways to improve and modify a certain technique because that's who we are. We are perfectionists. We try to make things better. So what are the surgical steps? Let's start. First, we're going to do treatment planning. That's the first thing you do in any procedure. You always treatment plan first on any surprises. Then we're going to do the window preparation. That's where you design the area where you're going to go into the sinus. Then you're going to lift the Schneiderian membrane. That's the layer that's inside the sinus that's protecting your sinus during any infections. Then you fill that space up where you lifted the membrane with anything. Some studies even don't put anything in there, but I will explain to you the difference. Then you cover your surgical area with a collagen membrane. You can avoid that sometimes, and I'll explain why. Then you close the surgical area. You always want to achieve primary wound closure because if you leave the wound exposed, you can risk anything getting in there. And if one infection starts, everything gets lost. Then you want to give your prescriptions. Alrighty, so let's start with the treatment planning. First off, you always want to consider the patient's anxiety level. I'm sure as dentists, you hear about a procedure and you yourself get anxious. Oh my God, a Le Fort 1. How am I going to do that? I know the first time when I saw it, I was anxious myself. So what about a regular patient who's never done a sinus lift and you tell them you're going to go into their sinus and you're going to lift the membrane and you're going to put bone? They're going to get anxious. You may want to consider IV sedation or, oral sedation to calm them down, Social habits, do they smoke, do they drink, what's going on? Because these things can make things more complicated after the surgery. You want to make sure that your patient discloses everything and you tell them what they should and shouldn't do. Any systemic conditions you have to consider. Do they have a cold? Have they had a recent history of a cold? That could mean that when you did the CBCT scan and the day you did the surgery between this time, did they develop any sinus infections during this time? So this is something that you have to consider, as well as any metabolic conditions, diabetes. Do they have any emergency related issues? Like, for example, asthma or history of angina or myocardial infarction. So this is something that you have to also put into mind. Any current medications that they're taking that could interact with the medications you're going to give after the surgery. Also, this is something very important. Periodontal health. I don't know if other people look at this like periodontists do, but I'll tell you this, studies have found that when you place an implant in an area where the patient has periodontitis or periodontopathic microbes, you increase the risk of the implant getting infected by almost an additional 50% right away, because these pathogens will make their way towards the implant. You will increase the risk of implant failure by about 4 times. Allergies and religion, because some of the materials that are being used, such as bone graft or such as the membranes, are against some people's religion. So you always want to disclose these materials, you know. I know patients that are Muslim that cannot get any pork-related materials. They don't want to, you know, and after you put it and you tell them, you know, this is what we used endogain, they're going to be very upset. Or you use any allograft material, even allograft bone, but the patient is, let's say, Jehovah's Witness, and they do not want you to transfer any material from another human being, and so on. So you have to consider this. It's a very nice, it's simple, it's very simple, yet your patients will love you for it. Now for the implant site consideration, we have to look at the blood supply, the sinus septa, the sinus pathologies, the Schneiderian membrane, the palatonasal recess or bucconasal, the residual ridge height, the corticosinus wall thickness, and the ostium. Oh my God, this is a lot. Let's go through them separately, but quickly, because I want to get you guys into the next topic, which is GBR. It's just more interesting. So for me, I like to sometimes have some fun and 3D print the patient's arch, because I can then explain to the patient using this model, and or I can use it to treatment plan. So I was looking here at the sinus of the patient. I drew a small black line you can see in the upper picture where my wall should be. And I, you know, just for fun. You don't have to do this for every case, okay? But again, what we need to be aware of is the blood supply. So there are 3 arteries that supply the maxillary sinus: the infraorbital artery, the posterior superior alveolar, which we all know, and then the posterior lateral nasal artery. The PSAA is the one that's going to be in the way. It's going to be right in the middle of the area that we're going to do the window. So you always want to understand the distance. How far is it from the crestal arch? These numbers can vary as, like we said, you have ridge resorption, so then that distance will shrink. Average studies have shown it the distance to be between 16 to 18, up to even 19 millimeters. For me, I say, can you see it in the CBCT scan? If you can, then just plan around it. If you cannot plan around it and you have to go through it, that's okay. You may need to ligate it if it's more than 3 millimeters wide, but less than that is no problem whatsoever. You can always see it in the CBCT, not always, about 50% of the time, 50 to 60% of the time, you can see the artery in your CBCT scan. So for that, in our study, in our patient, we see it, it's right there. So that's great. Now, what's the difference if it's on the outside of the wall or inside? There is a big difference. On the inside of the wall, that means I can use the window as a protection. While if it's on the outside, then it may be part of, or inside the intraosseous, it may be part of my window preparation. Also, we have to consider septa. You see these septa in the sinus? So sometimes that is in the way, and we have to consider that. Our patient didn't have any, but these are some simple examples where you have to change your treatment plan and have to go around these septa because they make it difficult for you. Studies have found that there's an increase in sinus perforation about 50% when you're doing a sinus lift and there's a septa. How often do we see these septa? In about 30%. 1 in 3 patients have a septa. So sinus pathologies, there are many sinus pathologies that you can see in a CBCT scan, and you should always refer to the ENT specialist when you are not sure. The one that you don't always have to refer to an ENT specialist is the retention cyst. Other than that, you should always refer to a specialist, okay? Don't do a surgery when you think, oh, this is okay, I can get away with it. Now, for the window design. What you want to do is, when you're going into the sinus area, you want to keep a safe distance of at least 3 millimeters from any bone area. Why is that? It's because when you're going to the sinus, guys, you have a membrane. And this membrane is very thin. We're going to talk about it in a second. And so if you make a hole in it, you want to go around it. You want to go around it. So if you try to go around it and you hit bone, then you cannot expand. So giving yourself a leeway of at least 3 millimeters allows you to go around it, okay? Here we gave 3.1, you can see, and then 3.2. This is just on the CBCT. And then we gave the window height of 8 millimeters. Why is that? Because studies have found that, 8 by 8 or 8 by 10 is the standard window size where you can see everything. Can you go smaller? Yes, you can. You can even do 6 by 6 or 4 by 4. But that requires more skill, more magnification. So for me, I don't mind going the average window dimension. So that's how it's going to look. Perfect. Alrighty. So now we're going to do our incision design. You're going to do a full thickness flap. You want to do vertical releasing incisions because you want to be able to reflect all the way up and to be able to see. These 2 small vertical incisions on each side will give you all that access. Okay? Let's look at the window preparation. So when we do the window preparation, we always use something called a Thompson stick. It helps us draw the area that we're going to be doing the window at. And then after we draw it, we use a high-speed round burr, and we go into that area slowly until we get to the sinus. You can either leave the center part on, we call it the wall-on technique, or you can remove the whole thing, and it's called the wall-gone technique. You can remove it and put it back on, which is the wall-off technique. But these 2 are the most common ones used. For us, we decided to do the wall-on. Remember, the artery was running behind it. So for me, leaving that wall right there, I am able to use it to protect myself from that artery. Now, we can see that that window is a little distal from the surgical area. Can I widen the window and move mesially? Sure. Yes, we can do that because we saw the CBCT scan. We can do that. And I'll show you what we did. But as we did the round burr, we used the round burr and we did the window, you start seeing this bluish hue, bluish colors. That is the membrane. That's the bone telling me I am now very thin and you are getting close to the membrane. That's when you want to stop using the round burr. You want to shift gears to your piezoelectric. This is the technique that I was talking about by Bertolotti. I'm going to show you pictures in a second. But before, I want you to understand the Schneiderian membrane that's inside the sinus. So it is a pseudostratified columnar epithelium, and it's about 0.3 to 1 millimeters in thickness. It can be thicker when patients have allergies or have any history of chronic sinusitis or even acute. But studies have found that on the CBCT, it overestimates this. When you look at the CBCT, the radiopacity of the membrane makes it look thicker than it actually is. So that should be taken into consideration because it is the most common complication when you perforate that membrane during a sinus lift. There are other complications, but that one is the most common. This is the piezoelectric. So we use these tips. They go inside the area around the window, as you can see. And with the vibrations in the water, it helps to remove the bone without perforating the membrane. So it's much, much safer. And then after we've done that and we've separated the membrane from the sinus, we use our hand instruments to push up. You can see the blunt, the non-sharp edges of the instruments are pushing the membrane, and the sharp tips are being placed right on the bone. And by doing that, you're lifting everything up. And then once you've reached the other side, because you want to get the entire width of that area to fill up the bone for the implant. Once you've done that, now you can either place the implant right now, or you can place the bone graft right now. So this is our window after we elevated it. You can see here, we actually expanded the window to the right by using something called a bone chipper or a bone crusher. So we just, took that bone and we were able to use it in the bone grafting harvesting part. Alrighty, so membrane perforation incidences. So this is what we're always being, always afraid of. Because once you perforate the membrane, you just added more time to your surgery. If it's small, it's easy to manage, but if it's large, that's when you get into a big pickle. For the thinner membranes, you increase the risk. A thinner ridge increases the risk. The presence of a septa, as we have mentioned before, and the angulation of the sinus. Because again, if the sinus is angulated in a narrow area, how are you going to be able to push up as you're elevating the membrane? So those are the most four. There are others, but these are the most common ones. We always like to check the membrane integrity. However, this is not always accurate, but you can always ask the patient to breathe, and you can see that membrane moving up and down. Small, teeny tiny perforations will not be detected in this method. You would have to see it yourself by putting gauze, absorbing that blood, and looking and inspecting. Always inspect, because if there's a small hole that you did not check and you start pushing that membrane, that hole can widen up. How do we manage it? There are different classifications, 1, 2, and 3. Depends on where it is in the window. You can either put a membrane, or you would need to fixate that membrane, or even sometimes you may have to tell the patient that we're going to close up, we're going to let your body heal, and we're going to come back and try again. There was a case in the past where there was no crestal ridge between the gingiva and the sinus. They were connected. So as I was elevating the flap, I was planning on doing partial thickness here, but I was a little too centered. I wanted to be more buccal. And by doing that, I perforated the membrane right there, just because I disconnected the area that was connecting the gingiva to the sinus. So here, you see the perforation right there. So what I ended up doing is I just put a membrane inside the sinus. This is always an absorbable membrane. And then you fill up the area with bone and the defect that we were seeing earlier. Close it up. 4 months, 1 year. Look, 1 year, you don't have to wait 1 year. You wait 6 to 9 months. But the patient lives in Florida and she was retired, so she only comes back during the summer. Now, for our patient space filling, what's better? Using allograft, xenograft, alloplast. Studies have found that by using some allograft materials, or if you wanted to use autograft with xenograft, you will get more vital bone. And that's what we always want to see, vital bone. Look at the percentages. Puras cancellus, autograft cortical, these are all, 20 to 40% is a beautiful range. And you have less residual bone graft particles. You can also do PRF, which is the hype now. Well, it's been a hype for the last 10 years, but yes, studies have found that by using PRF in the sinus, it keeps the membrane elevated, and as it resorbs and goes away, these cells bring in all these osteogenic cells that can induce the bone formation. In our scenario, we used a mixture of cancellous cortical bone allograft. Then we covered the area with a membrane. You don't necessarily have to do that. Why? Because your sinus is a contained defect. It's a contained defect. Your body is now containing it inside your head. But I decided to put a membrane just to protect the area. I just wanted to make sure that everything was beautifully, protected. And then you want to achieve primary closure. I also recommend that when you're doing any surgery, look for any other problems going on. Does the patient have a recession? Does the patient have any lack of keratinized gingiva? Because the positioning of the flap can help sometimes make up for it. The patient had some recession, so we decided to advance it coronally, not only to treat that recession, but also because you want to overestimate you want to overpredict the possibility of that flap opening. And so by going over and suturing the way we did, horizontal mattress suture and single interrupted, you can release the tension and prevent any possible membrane exposure. That's a crystal image. Prescriptions. We're almost at the end. You always want to prescribe antibiotics, especially when you're dealing with sinuses, because you do not want to risk any infection. So I always give antibiotics. You always want to give steroids to reduce the risk of swelling. The patient starts swelling up in the face. Now she hates you for the next 2 to 3 weeks because she can't see anybody. Everybody's going to think that, you know, somebody hit her in the face. You want to try to give an antimicrobial rinse to help with the oral hygiene. You can also consider warm salt water. It's God's natural antimicrobial rinse. And then you want to give painkillers for the patient's comfort. Painkillers, not pain. I don't want to say opioids or any of those stuff because it's too much. Lateral sinus lifts have never been, in my opinion, have never needed anything more than ibuprofen or acetaminophen together. However, there are some patients that have a very low pain tolerance, and if so, you can always go the acetaminophen, codeine, or Tylenol 3 route. I have never personally advocated for that, though. You always want to consider what antibiotics are you given. Because, guys, I've seen it where the patient comes to me and tells me, please don't give me clindamycin. And I say, why is that? And they say, my stomach hurts every time I take it. My doctors always give it to me. So then instead of giving them clindamycin, I give them K-Flex or cephalexin. And they love it. They say, oh, I had no stomach issues. You can also consider that after the patient has a surgery, maybe the patient wants to get their prescriptions and go home and rest instead of standing in line waiting for their prescriptions. So stuff like this, you can call the prescription ahead of time for the patient or write the prescriptions the day before and tell them to stop by on their way to pick it up. For example, that you can do stuff like that. This is the 2 weeks. This is the 6 weeks. This is the 6 months. And we overfilled. Oh my God, 19 millimeters of bone height. So now we have more than enough bone. We can place an implant and a half. So what we ended up doing is design the surgical guide, as you can see here. And this is how we print the 3D printed guides. And then after flap reflection, we did the drill. Angulation was adjusted and the implant was placed in the area beautifully. This is a 4.7 by 11.5 millimeter Zimmer. I believe it's a TSV. Yep. So to conclude, always know your anatomy before you do any kind of surgery and double check the patient's medical history for any contraindications. Always check for local factors, anticipate complications. It's okay to ask for advice or help from others. And give the patient a good experience when you're doing any procedure. IV sedation helps. And then I always say choose the best treatment plan for your patient and not yourself. Okay? And for that, I'd like to open the floor for any questions. I apologize if I went over my time. And thank you very much for having me.
Thank you so much, Dr. Sinjab. That was
yes. So, okay, according to the literature, the prevalence is, we said 1 in 3 patients has the septus. So the correct answer is 30%. The PSAA can be detected in a CBCT image approximately 60% of the time. That is correct. 50 to 60. And then the safety elevation threshold during the crestal approach is actually 5 millimeters. This is according to several articles such as Stuart Fromm, and then we have another article by Jordi Gargallo recently in 2019. 5 millimeters would be the correct answer. What it means is that if you're doing the crestal approach and you lift the membrane more than 5 millimeters, you increase the risk of a perforation, unless you're doing the SCA technique or the using the piezo. A disadvantage of using the crestal approach over the lateral approach is limited ability to elevate the membrane. That is correct. That is correct. Beautiful. 66% got that right. And then the bone graft found to have more vital bone is allograft. Definitely. Yes, you are right, because it has some BMPs. Keeping the bone of the surgical window during the lateral sinus approach is called the wall-on technique. 74% got that right. Beautiful. Alrighty. Thank you so much, Dr. Uvo.
Okay, yeah. So go ahead with the questions you can see on the chat.
Okay, so I'm gonna look real quick. It says I'm from Ethiopia. Yes, this was from the beginning of the conversation. I'm from Syria originally. I forgot to mention this. So I'm originally from Syria, but I was born and raised here in the US. And hopefully one day I can come and visit Ethiopia. I've heard some very beautiful things about the people there. So one day. What should be the size of a membrane perforation that would be a concern? I wouldn't say there's a particular size. It's a matter of whether you can go around the perforation and still elevate that membrane. So if it's a pinpoint perforation, or if it's 4 to 5 millimeters, as long as you can go around it and push the rest of that perforation out with the rest of the membrane, and then you can put a collagen, absorbable collagen membrane to protect the bone graft from getting sucked in. Now, of course, bigger perforations are much harder to manage. So it's just a level of expertise. Me personally, I think the biggest perforation I've had was about 5 millimeters, but it was more towards the crest. So I was able to protect it using a large collagen membrane. Thank you very much, Dr. Albert. Yes, I think Dr. Sinjab was talking about the perspective. But yes. So this was just from a periodontist perspective, and also oral surgeons. Yes, you guys have way more expertise in this matter, and I'm sure you are aware that this presentation that we just went over can be discussed in more details in about 5 or 6 different presentations. There's one just about complications and one just about pathologies. So we tried to simplify it today, but when a patient is being referred to you and you have the expertise, go ahead and do what you think is necessary. And thank you, Merci Oko, for thinking it's interesting. I really tried my best, and I figured that maybe by doing a case, it would be more interactive for everybody. Thank you.
Thank you so much, Dr. Sinjab, for this wonderful presentation. Looking forward to having you. We hope that we are going to transit this webinar series into a course that dental students all over Africa can participate in. That is the dream. Hopefully, we're going to be able to host it. And once we put the curriculum together, Dr. Sinjab, obviously, we're going to bring it back. And
so thank you very much for having
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator